So thank you very much for this nice invitation. It's a pleasure and a privilege to be here with you and share our findings here. So my talk was SPECT-CT and scintigraphy, and I will only talk about SPECT-CT because the scintigraphy is actually part of the SPECT-CT. So, and this is what I'd like to explain you in the next minutes. So this is the bone tracer uptake, bone tracer you can use. It's a diphosphonate, and what does it combine? You have the normal scintigraphy, and in 3D it's called SPECT, and with a CT you can combine it to a SPECT-CT. And this is the colorful images you can get. What influences the BTU patterns in this? So these are all the factors influencing uptake in the BTU, and this is important to consider. From my importance, this is the most important thing is the mechanical anatomical alignment, the type of the prosthesis, type of fixation, and you see when you go down to the list that this is a considerable number of points actually influencing these BTU patterns, and that needs to be considered, and you need to talk to your nuclear medicine physician. So what we use this standardized protocol to get alignment information, and with this alignment information you can get information about your position of the prosthesis in the coronal, sagittal and rotational alignment. And this is very important because without this information you can't really judge your SPECT-CT findings, because we know that the alignment of the prosthesis and also the prosthesis itself influences majorly the BTU patterns. The reporting should be like this: assessment of the position and type of prosthesis, then look at alignment of the prosthesis and alignment of the leg, and then you look at the planar three-phase bone scintigraphy, combine this with the SPECT-CT BTU pattern analysis, and then finally make a report together with your nuclear medicine physician. It's more like looking for a pattern than looking if something is hot or not. So if something lights up, that doesn't tell you there is a pathology there. It might be the area which is not showing increased uptake, which is the pathological one. So we have published this concept of pathological tracer uptake patterns. You can read this. We also looked at what is normal and what is not. So if you don't know what is normal after a total knee, then it's hard to judge what is pathological. So I'd like to go through some of these findings we have actually done in our studies. So for a normal prosthesis, if you have more posterior slope, then you will always have uptake in the area marked with the arrow. And this is a normal finding. If you have more varus or varus leg axis, then you have more uptake on the medial part. This is also can be a normal finding. And for a valgus, you have it more on the lateral side. And we also know that if the entire patella lights up, this might be just remodeling, or it might be instability. If you have uptake patterns on the patella more on the medial or lateral side, this highly reflects to malrotation of your femoral component. So going through some of the pathologies, you see this typical pathology-related uptake patterns for the tibia. If you have uptake at the entire area of the bone under the plateau, this relates to loosening, and also you have to look at the pecs and the keels, which are the most important areas. For loosening of the femoral components, it's about the same. You'll have to look at the tip of the TKA, you look for the pecs, and also look for bone gaps and radiolucent lines in the CT part. It's not only looking at the scintigraphy alone, you also have to look at the other parts. And for the patellofemoral, I've shown some pictures already. You see uptake on the lateral part of the patella. This high relates to internal rotation error of the patella. I'd like to show you some case examples. One case, persistent pain 1.5 years after TKA, never pain-free, very stiff knee. When you do the analysis, you see 14 degrees flexion in the femoral component, 4 degrees of internal rotation, and you can see the patellofemoral overloading on the lateral side. And then another case, you see anterolateral knee pain, also 1.5 years after TKA. And in this x-rays, you see heterotopic ossification, and it's causing soft tissue impingement on the tibial component. And then this is loose or not. The question always comes up when you look at scintigraphy, is that loose or not? And this is a varus-aligned knee, so that doesn't represent a loose component. This represents just tibial stress due to a medial compartment overloading in the medial part. And then finally, this unclear pain, tibial pain, you see the tibial stress due to stemmed non-slotted TKA in these parts. Last case, patellar stress, again, you see it on the lateral component. The evidence we have for loosening is very high. We can say that loosening on the femoral and tibial side, also patellofemoral overloading, can be diagnosed in a correct number. You see this is a large study we did on 100 patients, and you can see this also in other studies published by other groups. In this study, it's not so high, so you see 16% diagnosis and treatment changed, and this is actually interesting because I think this highlights one point I'd like to make. At the moment, SPECT-CT is still an expert tool, so you really have to sit together with your MSK and nuclear medicine physician and discuss the findings and then find the perfect diagnosis. It shouldn't be just looked at hot or not, and this is something I really like to highlight here. Thank you so much.